Sandra asked me to do a short presentation of the next conference of Dr. Paul. I thought about the shorter way to present. Paul, please. She is going to talk about salt, and just to let you know about what this our speaker did to come to Brazil. He came from China on last Monday to home in New Orleans. Then he got 12 years at home, got another flight to Brazil. It's with this health that we're seeing here. I hope to have that. Please, Paul.
Thank you, Flavio. And again, what a pleasure it is to be here. And I have to say, I enjoyed your presentation very, very much. Very, very interesting. And I enjoyed the posters. There are some wonderful posters. So thank you for, again, for having me. I'm going to talk a little bit about sodium and cardiovascular disease because just like the earlier talk, it's an area that seems to have ongoing controversy forever and ever. And there are strong beliefs and there are strong commercial interests. So just want to say what I think, where the data stands. So we could start by saying the requirements for sodium in a normally functioning human kidney that isn't impacted by drugs that interfere with the system or doesn't have kidney disease, you need very, very little. There are many instances of isolated populations that don't have access to sodium that live quite well on very, very low intakes of sodium. The real question for most societies is, given that sodium is a part of the food processing system, how much do you need to get an adequate intake of other nutrients and compensate for perspiration under unusual circumstances? In the US, we went through an exercise on this several years ago with the Institute of Medicine, and these are the sorts of levels that were thought to allow for adequate intake of the essential nutrients. So the highest intake being 1,500 milligrams, getting to somewhat lower adequate intakes in older age ranges. Recommendations for sodium intake vary all over the board. The American Heart, influenced largely by this sort of data and by the experience in the DASH sodium diet, it recommends less than 1,500 milligrams per day. The US government recommends the same for a majority because these subsets of the population represent a slight majority of the US population. And 2,300 milligrams, less than 2,300 milligrams for all others. Institute of Medicine just went through an exercise recently. It was a very unusual exercise where they actually ignored or were instructed to ignore most of the information and only focus on epidemiologic studies related to cardiovascular outcomes, which to my mind is the wrong way to go about it. But even under those circumstances, recommended less than 2,300. And WHO came out quite recently, a few months ago, with a recommendation for less than 200 milligrams. So somewhat over the board, but ranging from less than 1,500 milligrams to 2,400 milligrams in the UK. Well, when we look at consumption in most countries, and I'll show data from the US, we have two ways to try to get at it. In the US, we have very representative data from the NHANES studies, but it is by way of dietary recall, which is not a very good tool for assessing sodium intake, and it also excludes sodium added at the table. Recognizing that, you know, the levels are pretty high in both men and women and have seemed to rise. Not a surprise, because sodium is exquisitely related to calorie intake. And we know calorie intake has been going up, so it's not a big surprise that you would see sodium intake going up as well, despite our efforts to moderate it. So at a minimum, you'd say imperfect data, but no suggestion that we're reducing sodium intake. The other way we can try to look at it is using a better assessment tool, 24-hour urine intakes, but we don't have that yet from representative samples. We will get that from NCHS going forward, but for now, the best we can do really is look at clinical trials, which we know to be very much not representative samples. Bearing that in mind, same sort of thing, no evidence of a decline and intakes in the order of 3.5 to 4 grams of sodium per day. So between the two of these, you know, your best assessment would be that we, like most societies, are consuming far more than any recommendation would put forward, no matter how lenient the recommendation. And that's not a big surprise, because when you look at the sources of dietary intake, of dietary sodium intake for most of us, it comes not from natural sodium in the food chain, and it really doesn't come at the table or during cooking either. That really constitutes, in most societies, less than 20%. It's a little different in Asia, but in most Western societies, about less than 20%. And the vast majority of the sodium that we get is added during the food processing for a variety of different reasons. Most of them have to do with commercial reasons. They really have little to do with any health benefits. So if we look at support for guideline recommendations, it will come from many sources. I won't deal with laboratory or animal investigations today. We have a lot of human studies, a lot of cross-sectional studies, prospective studies, lots of migration studies, and randomized controlled trials. Let's look first very briefly at some of the observational studies on the relationship between sodium and blood pressure. And here I think, you know, there are a couple of good studies, but the one that stands out is really a study that was well designed because its primary purpose was to address this question, is the Intersol study. It was cross-sectional. It was designed to get contrast in the exposure, looking for populations that were known or assumed to have very high intakes, very low intakes, and lots in between. Pretty good sample size, about a little over 10,000 men and women, studied in 52 centers in 32 countries. And as I said, designed to get, just like a clinical trial, designed to get a wide contrast in the exposure variable. They use a standardized protocol with high-quality measures for ascertainment of blood pressure, sodium, which was obtained through 24-hour urine excretions, and for a number of the key potential confounding variables. And they did a variety of analyses, and without going into great detail, whether one looked at the relationships within population, essentially going to every sample and then combining them or doing a meta-analysis across the samples, or looking across the populations, or looking across age, there seemed to be a strong relationship, very much so when you adjusted just for age and sex, but even with further adjustment, an important relationship, particularly in the higher age group. There have been a number of migrant studies done. My colleague Zhang He and I and others have been interested in the E people for a long time. They live in a number of countries, but tend to have much of the population living in southwest China. They live a fairly simple agricultural lifestyle. They don't have access to much sodium, and their blood pressures in the native environment are fairly flat. They don't see much increase in blood pressure with aging. As soon as they migrate locally, just really over the hillside, and start buying their food from stores and getting processed foods, we start to see them take on the appearance of the age-blood pressure relationship that you see in most Western countries. And there's a striking relationship between sodium intake and blood pressure. It is modified by level of weight and it's modified by age, but it's striking throughout. There have been a number of other migrant studies. I think another good one was looking at the Kenyan Luo migrants who migrated from the countryside into Nairobi. And there was a group in the native environment shown on the left side here, compared with the group that migrated into Nairobi. From the first month, they started to have a difference in the pattern of their distribution of blood pressure. And they were followed for 24 months, and they had a progressive shift of the group that had migrated to the city. And it was related to a number of factors, but very exquisitely related to sodium intake. So migrant studies have also tended to suggest a relationship. Looking at observational studies for sodium and cardiovascular disease, we have a lot of problems. It's just a very challenging area. There are a lot of methodologic problems. Reverse causality is important. Many studies that are, especially ones that are being reported right now, are being done in cohorts that have patients that are sick in one way or another, either have hypertension, heart failure, diabetes, chronic kidney disease, or a variety of other underlying problems. And in this setting, many people have been advised to reduce their sodium intake. Some who were quite sick have poor appetite and reduce their sodium intake, and those individuals are the most prone to get cardiovascular disease. And especially in the heart failure cohorts, they're usually taking a lot of meds, including a lot of loop diuretics. And they also tend to, these diuretics will tend to distort measures of sodium intake, particularly the less powerful ones. I would say these studies are highly prone to reverse causality, and it's not surprising that you might see J-shaped curves or inverse relationships. There has been an attempt to exclude the first years of follow-up, but it's been pretty well demonstrated. While that's worth doing, it's not a satisfactory solution to the problem. So I would say these studies have to be interpreted with great caution. I'll just show one example of a study that received great notoriety in the press. You know, about the day after, the London Times, the Daily Telegraph, the New York Times were all saying, well, you don't have to worry about sodium anymore. In fact, low sodium is dangerous for your health. So it got very hyped up. And this was a U or J-shaped curve that was noted. In an analysis, secondary analysis, observational analysis of a large group of people who had been participants in 2 clinical trials. These were all people who were enrolled as being at high risk of cardiovascular disease. And they also had their sodium intake estimated from a morning fasting urine sample. So this is what was reported, but you know, when you really look at it in depth, the uptick really in risk is down in the lower 3%, and I would say you'd have to be really cautious about interpreting what's going on down here, because a J-shape is quite likely in this group with serious underlying health problems. The second issue, of course, is measurement, and it goes without saying that measuring sodium intake is very difficult. It's not as difficult as some other nutritional variables, but it's very difficult. And there are large day-to-day variations. 24-hour urine collections would represent the gold standard, but even those are not very satisfactory in most studies. Unless you're exquisitely careful in the methods and in the quality control applied to those methods, you'll almost certainly see under-collection. People don't like taking their jugs with them to work, having them at home. They tend to forget. You don't usually see over collections, but you do tend to see under collection. It's very common. And of course, that can result in systematic error. Some of the other approaches to measurement are less satisfactory even than the problems with 24-hour collections. And I just again show one example of a study that received great notoriety. This was a study done, it had the strength that it was done in a general population, not a huge population sample, but a nice period of follow-up, pretty low-risk group. What they reported is that comparing the highest to the lowest tertile of sodium intake, they reported a big difference in cardiovascular outcomes, both fatal and total. But when you really looked at the collection, between those upper and lower tertiles, there was about a 8 to, let's say, 10% difference in weight. But correspondingly, when you looked at volume and 24-hour urine creatinines, which they did publish, there was a substantially greater difference. So that pretty clearly indicates under collection of the sample and strong potential for bias. You certainly can have the problems of confounding, not unique to studies done in this area, but they're there. Many times the confounding variables haven't been measured, or even when they're measured, they're not measured very well, and evidence of residual confounding is quite common in the studies that have been published. You also have the problem of collinearity, that there's a lot of relationship between different nutritional variables. Sodium is related to lots of other things, and it's really hard to know the causal relationships. So I would say, in summary, when you're looking at observational epidemiology in this context, there's great potential for systematic errors, which would be the real problem. There's also potential for random error, which would reduce statistical power, but shouldn't change the direction of the relationship. And I think we just have to be really careful and only put any weight in the studies that have been really carefully designed, adequately powered, and really addressed specifically to answer this question. There have been a couple of meta-analyses done. This was done by the group from Italy and the UK, looking at the relationship between sodium intake and stroke, and there was a fairly consistent relationship, higher sodium intake associated with higher stroke rates, but not great studies. When you get to looking at other types of cardiovascularies, coronary heart disease, cardiovascularies in general, moving away from stroke, it's very difficult to make any sense out of the studies. I'm a part of a group that will be publishing soon. We're doing some work for the American Heart Association, and I'm obligated not to speak specifically to what we're doing, but I will just say independently there are about 26 prospective studies that allow you to look either at overall cardiovascular disease or coronary heart disease. They are bad. Significant positive relationships in about half, J-shaped relationships in close to 10%, null relationships in about 40%, about 11%, significant negative associations in about 40%. The problem here is they're really bad studies across the board. Whether you like positive or inverse relationships, they're not very good studies. They're particularly weak when you look at studies that have reported inverse and J-shaped, but I would say they're pretty much to a study. We're all pretty bad. So let's move to randomized controlled trials. Obviously, the strength of the randomized controlled trials is, if done well, there should be the potential to eliminate or at least greatly reduce many of the challenges that one runs into with trying to interpret observational epidemiology. A lot of the trials are small, and they're, best really viewed in the context of a meta-analysis. There are a couple of big trials. I chaired the 3 largest trials of hypertension prevention, phase 1, phase 2, and trial of non-pharmacologic intervention in the elderly. When you get past those three, you're typically into pretty small studies, even DASH, with relatively short periods of follow-up. Many trials are, to be charitable, irrelevant, and to be less than charitable, knowingly misleading, because they're either so short-term that they have no relevance, or they go about creating acute, dramatic, non-physiologic changes in sodium intake that would have no relevance for clinical practice or public health practice. So I think you have to set out in your protocol by discarding these sorts of studies. And obviously adequately powered studies done in the steady state and free living populations provide you with the best results, particularly for public health recommendations. When you look at those sorts of meta-analysis, and there are quite a few of them, typically what you see for lower sodium intake in hypertensives, about 5 to 6 millimeters of mercury reduction. For normotensives, about 2 to 3 millimeters of mercury. A little variation between different reports, but in general, that sort of pattern. There are two recent meta-analyses. There are always new meta-analysis these areas, but two recent ones. This one was done for the WHO when they were bringing out the report a few months back, and same sort of thing. You can see the eligibility requirement here. They included 36 studies with 49 comparisons, and they found no change in cholesterol. They found about 3.5 millimeter mercury and reduction in systolic blood pressure. This one here was a little slight differences in the eligibility requirement for who was, what trials were included in the meta-analysis. So a little smaller number of studies with 34 comparisons. Pretty similar findings overall, about 4 millimeters of mercury. Obviously, as you would expect, a greater impact in those with higher pressures compared to lower pressures. Obviously, when a clinician looks at the types of reductions that we see with normotensives, it's not very impressive. And I could tell you in trials of hypertension prevention, it's just like we heard from the earlier presentation. At 6 months, you get pretty nice reductions in blood pressure, and then it's really hard to maintain it if you're doing it behaviorally over the next 12, 18, 38 months. You tend to lose a lot of the effect. But even with small shifts in blood pressure, mathematically one could show, and many have shown, that small shift in the distribution should, by applying small benefit to a large number of people, result in quite substantial benefits, really quite similar to the kinds of benefits one would see with drug therapy of hypertensives. And these sorts of changes in blood pressure were exactly what we saw in TOPE and TONE. I show here TONE, just show one slide here, just to say that sodium reduction, of course, does even better when combined with some of the other non-pharmacologic interventions, and we saw that in TOPE, and here we show it in TONE. TONE was done looking at people who are already receiving antihypertensive therapy. Here they're on a single medication. Here's the baseline blood pressure is fairly well controlled. And in the context of this sort of pressure, to get an additional 5 millimeters of mercury reduction is as good as any drug would ever achieve. The challenge, of course, is maintaining that over the long term. What about randomized controlled trials as it relates to cardiovascular disease outcomes? Well, we have very limited information here. We have trends from a couple of studies, but none of these 3 studies that I chaired were designed to look at cardiovascular disease outcomes, clinical events. They were designed to look at blood pressure and treatment changes. But this one here was designed specifically to look at that question. I'll show a little more information. There are a lot of misleading trials that are being published right now, trials in particular have been received a lot of notoriety done in very high-risk patients with heart failure. And I have no idea why they're doing these trials. So what they're doing is taking very sick people, it's a group in Italy, they take very sick people who are on a lot of loop diuretic and are hemodynamically have been quite unstable, stabilize them, and then randomize them to low sodium intake or continue what they're on. And you could almost guess that in that consequence, low sodium intake would be potentially quite dangerous, and it has been. Having shown this in one trial, they've gone on now to do 6 trials. They all show the same thing, and I don't understand why an institutional review board would allow anyone to proceed with more trials, but they're not really relevant. They are relevant to sick patients with heart failure, but not really relevant to the general population question of do we use this clinically or should we use it in the population for prevention. The trials that haven't had enough power have been put together in a meta-analysis, TOPE 1, 2, and TONE. The Morgan trial is a very small number of events. And if you do meta-analysis, you get overall a reduction of about about 20%. But it's shaky, and it doesn't have much, doesn't have high confidence in those results. The trial, the only trial designed to address this question was a trial done in Taiwan. It's a feeding trial, very much like DASH. And essentially what they did is they randomized 5 kitchens for about a little under 2,000 veterans in Taiwan. They randomized them either to receive regular salt, sodium chloride, or a lower sodium salt with about half of it potassium replaced sodium. So it's 50% almost 50% KCl, 50% NaCl. And you can see the sort of pattern that they got. The outcome here was cardiovascular disease mortality. There's not great data to look at the intervening variable to know what happened to their sodium. There is some information on it, but not much. But the outcome information is quite striking, and of course you'd like to see that replicated, and it hasn't been replicated, but big differences in the hazard ratio for cardiovascular disease mortality, for hospitalization requirements, for cost of care, and a few other outcome variables. We did an interesting exercise in the trials of hypertension, phase 1 and phase 2. Nancy Cook was the PI on this, and essentially what we did passive follow-up after the trial was finished. Here is the trial for trials of hypertension phase 1, and here is the trial for phase 2, a longer period of trial. And then we followed people passively to see what happened to them in terms of mortality, and we had contact with the participants in this instance, and we were able to generate from them information related to morbidity. After the trends were there without any adjustment, and after adjustment for some of the key potentially confounding variables, there seemed to be a pretty impressive relationship both for incident events and for cardiovascular disease mortality, with the lower event rates being in the group that had originally been assigned to lower sodium intake. We also did some studies that I won't show here in the study cohort at Hopkins, showing that the hypertension prevention effect seemed to persist over a much longer period of time as well. Now, many people say, appropriately, that this is not great data from clinical trials, and it's not. And there have been many editorials saying, before we should recommend this to the public, we should have a randomized trial. But I think that's bogus, because when it gets to prevention, randomized trials are great for looking at subsets who have high event rates. When you get to looking at physical activity, or you get to looking at sodium intake, or you get to looking at cholesterol change, it's really hard to do randomized trials with clinical outcomes because it's just, they're not well suited, and you would have to have a huge sample size with prolonged follow-up. The estimate for sample size using a traditional design with 5 years of follow-up to address the question for sodium reduction would be about 28,000. And I could be confident that no one is going to fund that. There's just no way that that's going to get funded. So I think people who call for these sorts of trials know full well that they can't be done. The only way you could probably do this is with a feeding approach, a clustered feeding study. And one such trial is being implemented in China right now, and I hope that it can go to its full fruition and be helpful. I think for the moment, it's more likely that we will have to focus on meta-analysis of events from the blood pressure trials that were done to look at blood pressure change. And that's the best evidence we're going to have. So just like many other areas in medicine and public health, we have imperfect body of evidence, and we have to try to make rational decisions then with the best interests of the public at large. I think when I look at it, it's clear that populations consume sodium well in excess of their physiologic need and well in excess of any guideline that has ever been recommended. And this is almost all coming from food processing. And I think we have to ask the question, why is it ethical and morally and responsible from a health point of view to add sodium to foods without demonstrating that that is safe? And there's no demonstration that it's safe. So I think rather than putting the onus on people to say we show the health benefit for reducing sodium intake, I would take the stand that if you're going to add an enormous amount of sodium to the general population's intake, you are obligated to show that that is safe, and that has, of course, never been done. High-quality observational studies have shown positive relationships between sodium and blood pressure. I think when we get to the observational studies looking at sodium and clinical events, they're all suspect. Even when you like the outcome that is published, they're not good quality studies. Randomized control trials clearly indicate that modest sodium reduction lowers blood pressure, and meta-analysis in individual studies suggest that they reduce cardiovascular disease events as well. I don't know that we're going to ever get a completely satisfactory randomized control trial to answer this question of does lowering sodium intake reduce cardiovascular disease events. But I think the existing data is sufficiently strong to support the guidelines that recommend population-wide reduction in sodium intake. I'm not as concerned as others as to whether the American Heart is the right guideline or the Institute of Medicine is the right guideline. I subscribe to the American Heart recommendations, but I don't really care because we're not near any of those recommendations. And I think the challenge we have is implementation. And that's a great shame because of all the public health strategies that we have available to us, this is the one that we could really make work. The challenge of getting people to lose weight, the challenge of getting people to exercise and maintain that over a long time is very substantial. Here, we could progressively reduce the sodium intake that we have already added to processing of foods, and it can be done and modify the taste buds of individuals, and that would be an immensely easy, if you will, public health strategy, and I think an immensely effective public health strategy. So I suspect this controversy is going to continue to rage for a long period of time, but I think the evidence is strong and compelling to recommend and to work with the food industry as best as we can to get reductions in sodium intake to food, at the same time continuing to encourage people to change their behaviors, but that strategy on its own is almost never likely to work. Again, obrigado.